So, I was given this topic, monitoring. Now, we all do it. We monitor because we need some metric by which we can talk to our patients, educate them, and make changes to their treatment. HbA1c has long been accepted as the gold standard for monitoring for the last 2 to 3 decades at least, but we know that it comes with several limitations. We know that ethnically, for example, we have differences, hemoglobinopathies, anemia, pregnancy, other comorbidities can all affect your A1C levels. And we also know that A1C is a very coarse metric, day-to-day fluctuations, hypoglycemia, these things aren't picked up by A1C. So what next? We progress to SMBG, these self-monitored blood glucose levels. They're very good because it allows you to interact with your patients, and it allows people with diabetes to take control. They get real-time data, and they can actually promote behavioral changes as well as improve their understanding of the diabetes, of their own diabetes. Equally, it helps us look at patterns, make an assessment of their glycemic control, and encourage them to optimize therapy. We can do it intensively, moderately, or low intensity. But the point of monitoring is to make sure that we get enough information to promote a dialogue with our patients to help us bring about behavioral change and change in therapy. A value that's not looked at, a value that's not leading to some kind of a change is of no value to either us or to the patient. So please look at their books when they bring in their monitoring. However, SMBG comes with limitations. Any one reading gives you a snapshot, but what you really want is the full movie of the whole day, which an SMBG doesn't give you. If you look at these readings, you might think, not bad, right? Nothing's too bad. Maybe the dinner time one looks a little high, but actually it doesn't tell you the full story. What you may not see is that one of those readings was on the way up, one of those readings was on the way down to a hypo, and this whole detail of what happens in between the readings is missed. You can have the same A1C by having fluctuations this big. Remember, 40 to 120 will still average out to 80, or you can have the same by having readings between 80 to 120 averaging out to 100. So you can get to the same reading having huge fluctuations, also called glycemic variability, with troughs, hypos, and peaks, hypers that are unpicked up, or you can get them with a much narrower band like that. Okay, hang on. Okay. Never mind. So, a narrower band like that. The contribution to the A1C can all be within range, or you can have an average because of readings that are much above and much below. And this is the concept of time in range. How many of your patients' values are actually riding in a band where you think their control is good and optimal for their care? Guidelines have developed over the last decade, a little over a decade, to the point where we now have this concept of a time in range, the percentage of time we want any one of our patients to spend in that range, and what we define as time above and time below range. Broadly speaking, we must individualize the time in range to every patient, but broadly speaking, for type 1 and type 2 diabetes, we consider a target range of 70 to 180 for most people to be in range. Elderly, more vulnerable people with comorbidities, maybe you might accept either a narrower range or less time spent in range. So the time in range is two factors: the value of the blood glucose and the amount of time that you spend in that. So you can relax the time, you can relax the range. Whereas in pregnancy, you really want to tighten up both. You want the pregnant woman to spend much more time in a range that is suitable to guarantee good outcomes for pregnancy. And pre-pregnancy planning, type 1 diabetes, the ranges can be set. If you acknowledge that there is an ideal time in range, then we have two things. There are always going to be readings above range, there are always going to be readings below range. So this is time above range and time below range. Again, you individualize it to the patient, to the condition, and to their particular vulnerability and their clinical outcomes. However, the priority is always going to be to minimize time below range first and then fix the time above range. So always get rid of the hypos first and then work on the highs. And again, this must be individualized, especially for the elderly or vulnerable population. The time below range should be less than 1%. Remember that when you're looking at 24 hours, even 1% of that is a good 14 to 15 minutes. So spending a hypoglycemia of 15 minutes is significant for a vulnerable patient. Time in range correlates really well with HbA1c. I'm okay for time. Really well with A1C, and an approximate 10% improvement in time in range translates to an approximate sort of 0.5% improvement, 0.3 to 0.5% improvement in your, 0.8% improvement in your A1C. This is significant because when you're looking at patterns that are wildly fluctuating, you don't need to firefight on every single front. Supposing you have a postprandial excursion that's high, fix that after lunch. Fix that after dinner. That 2 hours that you improve is a 10% improvement in a day. Out of 24 hours, you improve one postprandial reading. That's a 10% improvement, and that will improve your A1C by about 0.8. The reason this is important is because we've started understanding over the last decade or so that improving time in range, both in type 1 and type 2 diabetes, has a significant improvement in terms of outcomes. So look at somebody who spends 60% of their time in range versus 80%. And remember, this 20% is probably just literally fixing maybe an after lunch and an after dinner excursion. 2 hours here, 2 hours there. That will be a 40% improvement in your time in range. And that will take your myocardial infarction from 3.3 to 2.3, for example, your risk of end-stage renal disease, visual loss, and amputation. So every single metric is improved by improving your time in range. We know that for every 10% that you can improve your time in range, the risk of retinopathy decreases by 64%, nephropathy by 40%, and neuropathy by 25%. So every single 10%, every 2-hour window is worth fighting for. How do these compare? An A1C is a broad brush stroke. It gives you an idea of how the particular individual is doing over a period of time. It's very well validated. This is the metric used in most of the clinical studies, and the A1C isn't going anywhere. We're going to be using the A1C for quite some time to come, and we're still aiming to titrate treatment to an A1C. However, this SMBG and time in range, especially when deduced from either a 7-point to 8-point SMBG or from a continuous glucose monitor, give you much more granularity. Even within that granularity, the SMBG is like a series of snapshots. Think of it as a series of snapshots that you can try to link up to make a story. However, the CGMS derived time in range is the full movie. You're getting the full 24 hours, usually for about 15 days, 1 week to 15 days. So within these two metrics also, you get a much greater degree of granularity depending on which metric you choose. The utility of both these is that they can give you in real time an idea of what that person's control is at any given point of time, and therefore it will allow you to make changes in real time to adjust treatment or change behavior. So this is the full video. Maybe SMBG can be a TikTok video, and the HbA1c is just the movie poster, if you will, that you see once every 3 months. So I think, oh yeah, I'm in time and I'm going to stop here. So monitoring in a snapshot. Thank you.